So welcome, Dr. Thorpe. Patty, we appreciate you coming.
Thank you, Dr. Khan. It's like this is your life. I remember some of that stuff, and I appreciate such a nice introduction. And I want to tell you how glad I am to be here with this audience. It's always been a pleasure for me to come to Redding, and I remember being at your very first meeting. And I congratulate you on how it's grown and the success for this particular meeting. I'm sure many of you know each other, and it's just a really good feeling to come to speak to such a receptive audience and to hear the other speakers. I'm sure I can't even promise to be half as entertaining as his talk. And I really enjoyed his talk too, but what I'm going to do is show you a lot of pictures. You can relax, because what I want you to do is see images. And I want you to see the world, and the world, wherever you go, Walmart, different restaurants, the mall, the airport, it's a clinic. It's all a big clinic. The trouble is that people wear pants. We all wear pants because we all have learned long ago that it covers up your legs so that people aren't staring at your legs if they get swollen during the end of the day. Or there's so many people who have sores on their legs or other kind of abnormal skin conditions. So unfortunately, it becomes incumbent upon me and my colleagues to take pictures of people who come to clinic to tell you what to look for when you see these people, because most people are hiding it. And when I live in Arizona, where people can get very neurotic about how great their legs look and say, oh, I have to have sclerotherapy for this, and I can hardly see it, you know that most of the pathology in our legs is hidden by the way we dress and because we are bipedal, and other animals do not develop deep vein thrombosis and varicose veins like people do. So let's see, let me go here. The most dramatic and traumatic thing in deep vein thrombosis, which is related to our deep venous systems, is pulmonary embolus. And pulmonary embolus can be tragic. It can affect a young person, a high school person. This happens to be a college person or a NFL player. But they have knee surgery. They're doing fine. They go home. They may have even put them on Lovenox, but then they stand up, go to the bathroom, and have a massive PE. Then this other patient, which was very dramatic too, was extremely successful president of the Fry's stores in Phoenix. So you see, DVT and these types of diseases it's not a socioeconomic thing. You think a lot of poorer people suffer because they can't get access to good medical care, and that's true. But a DVT that embolizes to your heart can kill you, and it doesn't matter if you're a billionaire or someone who doesn't have any insurance. So this Mr. Flora, they thought he had a heart attack. And I want to bring that to your attention because an awful lot of people spend time in the ER, and people have to think, is this possibly a DVT? And you know that for sure, that a lot of people get faked out thinking that it's a cardiac condition because it gives them chest pain. So they spend a lot of time ruling out, and things have gotten much better in ERs now so that they have algorithms to try to figure out quickly if it's a PE, but an awful lot of time there's a delay in diagnosis. And he only, in fact, had this diagnosis at autopsy. PE causes about 50,000 deaths a year, we think. The epidemiology is not very good. So 20 to 25 million people have varicose veins, which is much more common. And the number of 2.5 million people for chronic venous insufficiency, I don't even believe that. I don't think we know the epidemiology of how many people suffer from abnormalities in their veins that cause their legs to either have an abnormal look or dermatitis or swelling. We do know that about 500,000 people have chronic ulcers, and we think it's about 3% of the Medicare population will have an ulcer distal by their ankles due to stasis disease, not diabetes. It's a very expensive problem for this country. But the pulmonary embolus is this silent killer. It's like the widowmaker in the coronary system, because less than half the patients who die of pulmonary embolism were ever diagnosed with a problem that could cause that. And 10% of people who get a PE die within the first hour. So if you survive to the ER and get diagnosed, at least that's not a bad prognosis in terms of survival, but the party line is that you have about a 30% chance of having another PE within the next year. This is a very rare picture. You can see that there's a piece of thrombus or thrombus forming in this femoral vein. Here are the valves, and here is a huge length of thrombus. Now, most of the time, the thrombus has formed so much that it actually occludes the vein, so that when you do a venogram from below, you don't see any flow here. You might see a collateral, but you don't see anything here. This is interesting because I just caught it in a frame, a time frame, where you could see the piece of clot. So you can imagine if this piece of clot just randomly breaks off from the wall where it's not attached very well, because over time it gets attached to the wall. It just breaks off, and a huge piece of clot that's this long goes up through your circulation, through the right heart, into your pulmonary arteries, and occludes flow into your lungs. So that's why these PE are so lethal. And most of the time what they do is they cause a cardiac arrhythmia. And most people who die of PEs die of cardiac arrhythmias. This is what happens when the PE goes up into the pulmonary arteries. You can see this filling defect right here, no flow out into this portion of the lung. That's because a piece of clot like that went up, fragmented, and went into each single main pulmonary artery and occludes the flow into the lung. Every day we think that 2,200 people die from cardiovascular diseases, but we really don't know how many people die of PE. It's estimated that about 2,700, these data are probably a few years old, die of PE. And we know that the data, the mortality data within hospitals over the last 25 to 30 years really hasn't changed. The number of people they count of dying from PE, secondary morbidities to other conditions such as surgery or anything else they're doing, really hasn't changed, despite the fact that we have different kinds of filters, temporary filters. We have alteplase, and we have more awareness. The incidence of PE has really remained stable. And I want to suggest to you that it's the number of people who die of PE each day is equal to several jets crashing each day. And we know, just based on the recent 737 MAX issues, that 2 planes within 6 months crashed and they stopped flying that plane. But yet the number of people who die of PE every day, every year, equals many airplanes crashing, and no one's doing anything different about PE, which I think is pretty amazing with the way that medicine is. It's just something that just continues to happen, and nobody's been able to impact it. You can think about that. The only way you can decrease PE, that's not working. No. The only way you can decrease PE is to recognize deep vein thrombosis, because you don't get a pulmonary embolus without having a piece of clot in your peripheral vascular circulation that embolizes to your lungs. So if you recognize the signs and symptoms of deep vein thrombosis, then you can preclude, I'm sure, a number of pulmonary emboli. This is a slide that just reminds us that this fancy kind of CTA with thin slices and a protocol for PE has increased our recognition of pulmonary emboli in the lungs, but it really hasn't changed the mortality. So now we can see them better. We can say, yes, you did have a PE, but it doesn't change the care, because oftentimes it's just too late. So keep in mind that it's difficult to diagnose both DVT and PE. Oftentimes it's masquerades as heart disease. The epidemiology is not well done in the United States or anywhere for that matter. And the incidence is really underestimated. You know how many relatives we all have that when you say, well, how did your great-grandmother die? And they say, well, she just died of old age. I mean, we just don't know how many people die from PE and heart disease, particularly in the past. So how would you know or suspect that you have a DVT? Well, I'm going to give you some clues that you kind of can keep aware of. If you have recent surgery or an injury, and then you're sitting around on a sofa watching TV and being immobilized because you can't walk very well, you don't have any energy, you get kind of a leg cramp or a little bit of swelling, you shouldn't just disregard that. If, in fact, you get shortness of breath, that's something you shouldn't just blow off either. If you get focal chest pain, that might be a sign that a small embolus went to a portion of your chest. And if you have low back pain, that's another masquerader. So people who go to the emergency room are often told that they have sciatica or a pulled muscle, but they should really examine you. So I'm recommending that if you have any of those symptoms and you've had that scenario of recent surgery or recent injury, that you demand that you get an ultrasound in the emergency room or in a good clinical office. And not only that, do they just do your legs, but they do your abdominal area. So they look at your iliac veins in your pelvis, because most of the emboli that kill you come from your pelvic veins, not from your knee vein or the veins in your calf. And sometimes a D-dimer will say that there's an acute thrombosis going on, so that will help as well. Now, what's the problem with this recommendation? You could say, well, gee, Dr. Thorpe, that sounds really good. The problem that I see it is this. Not all of the ultrasound techs are very experienced. I can tell you to go to Dr. Khan's office, and I'm sure he has an experienced tech because that's his business. But you might go to the community hospital on the other side of town, and you might have a tech that just got out of training, or they just do arterial work and they hardly ever do any veins. They're not even interested in looking at your veins, but they have to because they ordered the study. They don't know where your iliac veins are, so they can't look for them. They tell them just to look in the leg from the femoral to the popliteal, so your groin to your knee, and that's not where the big veins and the big clots are. They never measure your legs when you go to the emergency room. If one leg's bigger than the other, don't you think that's a clue that something's wrong? And if you have a clot in your leg might be 1 inch or 2 inches bigger. Then they also know that if you're going to complain a lot and they send you home on Lovenox or just tell you to take ibuprofen, that if it gets worse, you'll be back. They assume that. And most of the time they'll tell you it's just sciatica, you probably overdid it, it's muscle strain, and go take some ibuprofen. So if they really diagnose a DVT in your left lower extremity or right leg, they will put you on Lovenox, give you a prescription for Eliquis, and tell you to see your PCP. But even that is not a guarantee that you won't have an embolus or propagation or increased deep vein thrombosis. So you see, it's a really sneaky disease, and you're not protected by the, the intelligentsia of medicine, because it's very sparse. There are very few people who are venous specialists. So that's why I'm here to try to teach you for your own sake what to look for and what to advocate for. I had a lady go to the emergency room in Phoenix recently, and I insisted that she ask for a pelvic abdominal ultrasound because I know she had stents and I was worried that they might be occluded. But when she got to the emergency room, which I thought was a very good place, they have good tech, the ER doc refused to call the tech in. He says, oh, we're just going to get a CT instead. Well, CT is not a very good exam for flow in your veins. It doesn't examine it that well. It doesn't see the velocity. It doesn't see the flow through the stents. So you see, I was thwarted by the fact that I thought I was sending her to the right place with the right ultrasound people, but then he ordered the exam that was faster and told her to go home, and if she had any more problems, to see Dr. Thorpe, after all. You see, so I was doing my best to get her a good exam. Dr. Ricotta said this many years ago, and chronic venous disease is much more common than arterial disease, but what does that mean? This is kind of tricky. The ratio is 9-to-1. 9 venous patients, we think, for every 1 arterial patient. But you see, arterial disease is more recognized as being related to cardiac disease and certainly diabetes. And we have a lot more experience and many more physicians who are adept at treating arterial disease than venous disease. And the reimbursement for venous disease is not as good as arterial disease, so there's no particular incentive for a lot of physicians to go into that treatment because they're worried about the reimbursement. And that's an unfair thing because venous disease is half of your circulation. And if you don't have good veins, you don't have good valves, your legs aren't very good. You can have perfectly good arteries with a good pulse in your foot. And if your veins are full of clot, your legs are going to be really bad and you can't walk very well. So why is it that 30 years ago, the people who sat at the table decided that if doctors are working with veins and put a catheter in the inferior vena cava, you get paid half as much as if you put a catheter in the aorta? Will you tell me? So that's what we're stuck with. That's what we're stuck with. You should know that. You should complain. It's really sticky. Where am I supposed to point it?
Forward, please.
It seems like it might be wearing out a little bit. Okay, so 9-to-1 ratio. So where are all these people? Of course, we're all here in this room. And many people have spider veins. As I said, there are some people who are very, adamant that their legs look absolutely perfect. And so they can have sclerotherapy with both injection and laser treatment to get rid of spider veins like this. And they will dissipate. There's always a risk of some matting or staining because if any of the sclerotherapy gets outside the vein, you can get a little scar or bruising, brown spots there. But these, by most people's standards, are considered relatively minor issues in terms of pathology compared to varicose veins and blood clots. However, it's all venous pathology. So I don't want to minimize spider veins. Spider veins indicate that there's too much pressure in the venous system and it's manifesting as abnormal appearance of veins right below the skin. And it may or may not be related to more pathology underlying that, but it's a sign of some venous pathology of high pressure. Now, varicose veins like this also are. These, you can see, are very obvious in this left leg. Now, believe it or not, this young man came to me as a super international model, but he was modeling pants, so he was covering up his legs until they wanted him to do more like swimwear. And of course, he couldn't qualify for that because of the appearance of his legs. So when he went to his physicians in Sydney, they did an ultrasound. And it turns out that this is a clue for you. Have to advance for me, please. I'm sorry. His ultrasound showed that he had obstruction in his IVC and iliac veins. Now, if you see a teenager, man or woman, with varicose veins, I want you to think, wow, there must be a central venous obstruction here because it's not normal for young people to get varicose veins. Varicose veins usually are a manifestation of an incompetent valve in the saphenous vein system. But if there's quite a bit of central obstruction, it can cause a lot of pressure distally over time. And even as a teenager, they can develop kind of blown out veins that get tortuous like in his leg. So that was a clue that we could see, and he didn't really know when it happened, but he did come to us with a change, please. And this is his venogram that showed that he had, this is iliac vein, this is his right iliac vein because he's prone. This is what near the IVC, but a lot of collaterals, and so he was totally obstructed. See where I write that little track right there is the actual iliac. All of this is collateralization. Here's the iliac here. So it was totally missing for a long time. Well, we were able to reconstruct him with stents, and this was a number of years ago, and he's patent still, and he's never had to have a revision. And then what we did was we did get his varicose veins treated. And I want to impress upon everyone that if it's just varicose veins, they should be addressed. People's quality of life depends on that. The varicose veins like that can cause swelling, aching, your leg gets tired at the end of the day. So even though it's maybe on a level of 1 through 10, it's not the most serious. It's hard to separate them because your quality of life is very, very much dependent upon your legs being good and not swollen and not heavy. And all of this contributes to those feelings. Next, please. So that's how good his leg looked after he had his varicose vein ablated with radiofrequency, and that he also had the stents put in so he had good flow. And he and his wife, who's also a model, they live in Perth, Australia. Now, this is a patient of mine too, who you can see how bad his veins are. And I put the red flag there to remind you again that if you see a teenager with varicose veins, think, wow, there might be some central obstruction. And he, in fact, had an IVC obstruction, was referred to me from Dr. Glovitsky at the Mayo Clinic because he had never seen a patient with that much collateralization around an occluded IVC. And all of these years, Phil didn't care about these varicose veins. They look terrible. And I said, Phil, you can really get these fixed. Now you've had your stents now for almost 20 years and they're open, because I've seen him in follow-up over the course of the years. And I'm glad to say that in the past few years, he's been getting one at a time treated in Chicago. He lives in Chicago. So his quality of life has improved vastly because, you know, he lived with these for so long, since he was 17, that I don't believe he understood how much they contributed to the heaviness. He just learned to live with it. And there are a lot of your patients who might minimize their symptoms and poo-pah, I don't want to do that, it's just cosmetic. Those people's quality of life, each one of them can be improved if they have good venous care for the superficial system as well. So I know you can find a good superficial vein person here and where you live, and then have them evaluated. It's really important to make sure both the deep system and the superficial system are functioning normally to avoid this kind of combination disease. Now, I see a number of people who have, go back, whoops, we're going too fast here. Venous disease, which, sorry.
Go back, please.
If I think I'm going backwards, I'm going forward. Okay. Yeah, right there. This a very large varicosity like this. When I first started doing saphenous vein ablation and sclerotherapy, I was actually pretty afraid of these kinds of varicosities because they seemed pretty amazingly developed. But it's amazing how a combination of sclerotherapy, getting to the baseline of where the pressure is coming from, removing the saphenous vein if necessary, not removing it but ablating it, gives excellent results. It's not sometimes forever. You have to find the pathology deep and treat it from the basis. And it's not just cosmetic, you have to treat the underlying high pressure system to get rid of these kind of varicose veins that come up on the surface. But it's very rewarding and the patients really do benefit. So I very much encourage a treatment of the superficial veins as much as the deep system. Next. But a lot of people have the combination of iliac compression or chronic DVT in their deep system plus these varicose veins. So how do you separate all that? And what about quality of life? Do you treat everyone that comes to see you with a leg that doesn't look quite normal? And the question to me hinges upon their quality of life, and you have to analyze that. Next, please. This lady was complaining about her second toe on her right foot. I said, what bothers you the most? She says, my toe on my right foot. Well, the pulse is fine there. She'd had an arterial exam, and her arterial disease is not, she has a history of diabetes, but her arterial lennies were good, her ultrasound was good. So I said, can you walk? Yeah, I can walk anywhere I want. Do you wear stockings? No, I don't like to wear stockings. Do you have cramps? No, not very much. Well, I measured her legs, and her left leg is visibly larger. She has more varicose veins on the left. There's a little bit of dependent discoloration. And I said, well, has your left shoe always been tighter? She said, oh, you know what? Since I was a little kid, they always measure my shoes from the left side, and I get that size shoe because my left foot has always been bigger. So here is an unusual manifestation of deep vein pathology that she's accommodated to for so long that I can't try to convince her that her quality of life isn't good. She's 82. She can do everything she wants to do. She drives herself to the clinic. She's very articulate. And so I did the ultrasound evaluation, and she does have left iliac stenosis. But I am not going to be putting a stent in her just for a technical exercise when I know that a stent in her left leg will make her left leg look better and probably feel better, but her main complaint is her right toe. It won't make any difference at all. So we have to go through this process of judging our patients. So here, and doing the right thing by them. Now I want to show you a couple more signs of deep vein pathology. Do you see how red this right leg is? This lady has a thrombus that didn't resolve completely in her right iliac system. So she has dependent discoloration in her whole leg. This patient has an acute DVT. So he has redness and swelling in his right leg and probably an old bruise in the left ankle. He may have an iliac compression because this looks like some sign of chronic DVT, but this is the acute problem. Next, please. These are signs of chronic hyperpigmentation, which to belie a chronic DVT. You can see the swelling. There's probably acute on top of chronic there. You can see this patient had a saphenous vein harvested for a cardiac procedure, and he has some hyperpigmentation here, maybe a little bit here, but this right leg is the one that has had the DVT in the past, and he's not probably recanalized very well. Next, please. You can see this patient has chronic DVT on both sides, hyperpigmentation that's accumulated over the years, and he has one side that's been stented successfully and the other side that couldn't be successfully stented. But he has varicose veins, but he's very active and he travels all the time. So we improved his quality of life, and he still has the disease. This patient has a lot of swelling on this left side. Now, sometimes you have to decipher whether or not this is lymphedema and venous swelling, But you see the top of his foot is not puffy, his toes are not particularly puffy, so most of this is venous hypertension. This is chronic hyperpigmentation in the ankle area, indicative of high pressure from either old clot or chronic venous disease, and this is his left leg, so I suspect there's iliac disease. This is a patient with an ulcer, and I can tell you that there are a number of people in homes, people who are mentally challenged or people who have been put in assisted living situations where they're ignored. And they develop a lot of this kind of non-healing ulcerations. And when any nursing people see this kind of thing, they should be referred to vascular specialists because oftentimes they're treatable with iliac stents. And in this patient, his legs both healed once he was stented from old DVT. But he couldn't express that. You see, he didn't know how to say my legs bother me or I had a history. It's his parents finally brought him to me, and I said, yeah, there's something going on here. So a lot of patients are not capable of defending themselves in this environment. Next, please. This is an old scar, a white scar, a blanche star, indicative of iliac and IVC occlusion. Now a lot of our patients have tattoos so we can keep them apart. That didn't used to be the case. She has an IVC iliac stent successfully placed and has not opened her ulcer since. Next, please. Now, people don't show you this very often, but this is a lot of collateralization of the abdominal circulation to compensate for a superior vena cava obstruction from maybe dialysis catheters or ports. So this is another area where the deep venous system can occlude. This is a very large collateral in the lower left quadrant, indicative of IVC occlusion. So people cover these up. They don't show people very much, but unfortunately, some physicians who were gung-ho about sclerotherapy will actually try to remove these with sclerotherapy, and that would be the worst thing they could do because they're blocking a collateral that's really necessary for outflow. So how do we suspect that someone has a very common condition that relates to DVT or pathology in the iliac system? So I'm going to show you how you can notice that. They've never had a blood clot. They don't have a history. They're in themselves not worried about it. Next, please. Do you know that 1/3 of the population has an iliac compression because of the way that we're actually put together with the aorta and the cava? So your aorta comes down to your bifurcation near your belly button and splits into 2 big arteries, and your veins come up from below and join right about that same point. But there's a little bit of difference in everybody about where the cross happens of the artery crossing on the vein. There's a little bit of difference on the lower doses or curvature of your spine, and this artery is on top of the vein right in front of your L4-5 area of your spine. So depending on how you're made and how much curvature you have in your back spine and how high the bifurcation is on the aorta, you can get a difference of compression of that vein, and that is from the time you were born. So the earliest we know pathology-wise or reporting in the literature is a 2-year-old who was seen to have a compression of his iliac vein. And when the artery is pounding on that vein every minute, every hour, all day long since you were born, in some people it creates a lot of thickening of the vein wall. Some people, it just kind of compresses it, and the vein itself doesn't get that thick. It's variable in different people. So 1/3 of the population from autopsy reports that were done with very large groups of examinations showed that 1/3 will be found to have a very abnormal vein, and the bone itself might be spurred. And the vein will be either occluded or have boulevards in it, but it'll be narrowed. Well, That's a third of the people in this room have a compression. Whether or not you're symptomatic, we don't know. Is your left leg ever heavy by the end of the day? Is your left shoe tighter? Does your left foot look a little purple when you stand up? These are the kinds of things that start happening if it gets complicated with blood clot in your iliac vein. And when does the blood clot come in the iliac vein? Well, sometimes it comes after a very innocuous event, like starting birth control pills, but you're perfectly normal. Testosterone shots for men, but you're perfectly normal, but you take a hormone shot. Or you step off a curb and twist your ankle, and then you lay on the sofa in one of those boots for a couple of days. And you see, this iliac compression is a mechanical risk factor for blood clot formation, particularly when combined with anything else like hormone supplements or dehydration or too much immobilization, things like that, long plane flights, long car drives. So if we have about 300 million people in just the United States with an iliac compression, and they're the ones at risk for a blood clot, when you have these other additive risk factors, and we didn't even mention genetic risk factors, right? So you can see why human beings are subject to blood clot formation, particularly in the left leg. It can be the right leg as well because there are multiple places where the artery crosses the vein, but the left leg is the most common. Oops. You change it, go back one. So you see, when you put the legs together, you bring the knees up on the exam table and you look right at the ankles. That's the very best image that you can get to see if the left leg is bigger than the right. If both the legs are stretched outwards or you're just having them stand there, you don't often see this. But when you get this kind of what I call the pedicure view, you see the left leg is bigger. Next, please. This one as well. You see how much bigger the left leg is? This patient never had a blood clot, but she did have the syndrome of swelling, heaviness, progressive over the course of the day, and she would benefit from an iliac stent. Next, please. This patient, however, had a blood clot. She was after the fact. She had a May-Thurner compression, and she ended up getting a blood clot, and then she was left with the same kinds of findings, but after she had a blood clot. Next, please. So you see extrinsic compression of the arterial system against these bony structures creates this web, and it creates a risk factor for people developing clots. And this is the picture of how it can look in a cartoon-like image when you can see that the vein is smashed under the artery right where it bifurcates. So this would be the right side, this would be the left side. And you can see it takes different manifestations. Sometimes it gets all fenestrated, sometimes it just gets a boulevard, sometimes it gets very narrow because this gets very thickened. And you can see it quite well on CT. You see how the contrast layers in the vein. This is the artery, and you see the artery impinging upon the vein right here as it gets flattened out here. So we've run some articles about comparing all this with IVUS and with different CT. And here is another example of how, if you have a good ultrasound tech, and I know some of you in this room are very interested in doing this well, you have to try very hard in your iliac system right below the bifurcation without pressing too hard to see if you get elevated velocities at this point. Elevated velocities greater than usually 30 are indicative of a narrowing, and below that there's this telltale sign of non-phasic or flat line flow that drops off tremendously from 50 to 13 in this particular patient. And these are the telltale signs by ultrasound or CT that you have an iliac compression. Now you have to combine that with the examination about the quality of life and how their leg is and how much it bothers them, of course. Dr. Camarota wrote about that. So I want to go through a couple of myths for you. You know, I don't have my time here. Okay. So I'm going to just touch on a couple of myths because I think, you know, you've had a long day and you've had so much information given to you about cardiovascular disease, but there are a lot of myths floating around about venous disease, and I kind of want to dispel some of it. Venous disease is incredibly complex and difficult. Well, really think of your veins as pipes and valves. And it's really like it's a plumbing system inside your body. And when it's blocked, it's like a traffic jam. And the cars have to go around to all these detours. So I always describe the venous system with these kinds of metaphors to people. So it could simplify the sense that the blood is trying to get back to the heart, and it does the best it can to come back through the main veins and major collaterals when it's blocked. The superficial veins are often the ones you can see. They're closer to the surface, but there is a misnomer, just so you know, that the superficial femoral vein is actually very deep in the leg. So it's not superficial at all. It's in the middle of all the big muscles. And the muscles are important, and the reason those veins have valves in them is because when the muscles contract and relax, it pushes the flow up, and the flow keeps going towards the heart, and when you relax, it comes back into the valve, and the valve keeps it from going down further. Now, when people's valves don't work, they reflux or regurgitate. Those people get swelling in their legs because the valves aren't functional. If once in a blue moon someone is born without good valves, called agenesis of the valves, their legs look like elephant legs. They just have no capacity to move the flow forward. It just kind of goes up 3 and back 4. You know, it just doesn't work very well. So valves are very important, and the reason why you want to get the blood clot out of the legs as soon as possible when you find it is to preserve the valve function. Now, how many know how many valves you have? Between your groin and your knee, you have about 6 or 7 valves in your thigh vein. Between your knee and your ankle, you have about 100 valves. That's because when you were running to try to save your life from a saber-toothed tiger, I guess, the flow coming into your muscles in your calves has to be channeled into the deep system towards the popliteal vein, up through the femoral vein, up through your iliacs. And those valves are extremely important to keep things going forward instead of drifting backwards. So those valves are all very important, and that's where I like to address the treating blood clots in the popliteal behind the knee and in the calf is equally important as the bigger veins, because you don't want to get those valves destroyed. You want to have them for life. Let's go on here. We already looked at that. Well, this is just one more example of the iliac compression, and you can see how that artery sitting right on top of that vein has caused actually an absence of flow in a venogram. When the injection is from down here, the flow is forced into the sacral collaterals and through the ascending lumbar branch. So that's all indicative of high pressure right at this point, and that would have probably affected the valves in the left lower extremity. And there is some evidence of old clot right in here too. So can you see the left leg being bigger, the left ankle being bigger? This is a May-Thurner classic, and according to the literature, 1/3 of the people in this room have an iliac compression, and would probably, if we put you all in this position and examined your ankles, some of them would be larger on the left than the right. And you might not have noticed it yourself. What about another myth? Calf vein thrombosis is clinically insignificant and often not treated with much more than Lovenox, if at all, and certainly not long-term anticoagulation. Well, there's a controversy about that, but I hope I just told you that calf vein thrombosis is significant, particularly if your leg is swollen and you have a lot of clot there. It should be treated effectively to get rid of the clot. Now, if you look at almost 3,000 venograms that were done over a 10-year period, just to see what the causes of DVT were, you can see that 40% idiopathic means they didn't really know what caused the clot. That was called unprovoked clotting. It's just that we don't know enough about all the reasons that cause deep vein blood clots. We do know that 35% in this group were post-op and 10% were caused by malignancy, and then trauma at about 10%. And we know that if someone shows up with a clot in their legs and they don't know, they've never had clot before, you can say that about 10% of those people will have a malignancy because the reason they got a clot was the change from the tumor caused their blood to clot. Now, how often is it left versus right? Well, it's one and a third times more common on the left than the right. And most of the anatomy, if you see an entire acute DVT, you'll pick up 83% in the calf, 50% in the femoral popliteal, and only about 10% in the iliac. Now, when I look at these data, I think, I wonder if they examined them properly and looked above the inguinal ligament. But in fact, most of the people who have multi-segmental clot, it'll involve from the groin all the way down to their calf. The people who end up with just clot in their groin area, oftentimes it's associated with a tumor or surgery or a heart cath or some kind of invasive trauma. So when you see that DVT is in the leg, you have to question why it got there. And then it's good to follow it with serial ultrasound exams to see if it's getting worse over time. Even if you put them on Eliquis or Xarelto, it can grow. And usually it forms from the below to the, goes from distal to proximal. And embolization is totally random. We can't predict it. My sense is that it happens more from the right leg than the left leg because there's no natural bridge or blockage on the right side like there is on the left. And again, you can't ignore the importance of distal DVT in the calf. Does DVT occur in children? It does if you put central lines in them. Or you do invasive things like that. And there are a lot of kids who were born preemies that they had central lines put in them as youngsters, and they ended up with IVC occlusions by the time they're teenagers or young adults. But in general, DVT, the way we see it in adults, from sitting too long in one place or falling off a curb, it doesn't happen in kids. However, 3 of the young men that I've had with IVC obstruction that came to me in their late 20s with bilateral clot in both lower extremities have something in common. And I think it's a small series, but I bring it to your attention. They were all on soccer teams, and they were all soccer goalies. And so they caught the ball in their mid-abdomen so many times at such force, and they were little kids, for so many times that they actually traumatized their IVC, and then it accommodated them and had collaterals. But by the time they were in their late 20s, they all developed a DVT. And most of the time they got varicose veins. Somebody went in and did an ablation, and then they clotted off their femoral veins. So that combination is probably more common than we know. So there is a lot of controversy about how much anticoagulation, and a lot of trials have not been done to test the efficacy of Eliquis or Xarelto after you get angioplasty or a stent. All of the ads on TV are only predicated on studies that were done in Europe, which gave warfarin versus one of these drugs, Eliquis or Xarelto, to a bunch of people who had a blood clot, usually a blood clot in their femoral vein or popliteal vein, And they were probably, over time, equally treated, equally well off, equally badly off with warfarin. So you see, nobody has ever come in and treated all of these people with a good test, a randomized test, after they've had a stent or angioplasty or urokinase, or not urokinase, but alteplase. So I want to keep in mind that we have a lot of people who have failed these medications because we don't understand how thrombogenic it is to put an angioplastic balloon in a deep venous system and inflate it and put a stent in and wires, et cetera, pull everything out and then put them on Xarelto and wonder why next week they're clotted again, because none of these drugs are meant for that kind of use. Warfarin is probably still the best drug for inhibiting thrombus, and it's still the most problematic drug. And whenever you have a warfarin patient, I would encourage you to get them on their own home monitor as soon as possible, because it empowers them to regulate it and learn how to manage their own daily warfarin doses. I have many patients like that. Where are we in turn?
10 minutes.
Okay. So now maybe you're getting sleepy. I don't know, that was a really good. So I want to just mention the ATTRACT trial, if any of you are familiar with that. It was a trial that was done for a number of years trying to compare whether or not it made a difference if you gave people heparin versus thrombolytic therapy. I do believe that thrombolytic therapy wasn't given long enough in that trial, and their follow-up wasn't quite long enough. But when they measured just the people who had femoral DVT compared to whole leg DVT, they found a distinct difference in the benefit of thrombolytic therapy with people who had catheter-directed lysis. Because the data will show that if 100 people get blood clots in their thigh and iliac, not everyone is going to end up with the same appearance 6 months or a year later. Some people's bodies will dissolve that clot rather well, and some people's bodies will just solidify that clot. And the truth is, we don't know how to tell the difference between people who get recanalization or channels through their clot versus people who end up with just a blocked vein for the rest of their lives. So once we can figure that out, I think we'll be able to treat people better. I think it has to do with blood type. I think I've told you that before. I think that people who are non-O blood type have much more tendency to form clot. And if they do form clot, their clot is much thicker because they have a lot more fibrin in their blood. So just everybody go back to the days when they made mud pies. Everybody's made a mud pie, right? And how do you make a mud pie last longer or even build something with it? You put grass or straw in it. You find whatever you can to mix with the mud so that when it dries, it doesn't fall apart like a bunch of clots of dirt, right? So the truth is in blood clots themselves, in non-O blood type, there's a lot more fibrin if you look at the blood under a microscope. And in O blood, there's almost no fibrin. So the blood type in O is more amenable to penetration of the enzymes that secrete from the wall of the vessel versus the blood in A and B type blood, which becomes a denser clot and then is recalcitrant to the penetration of the secretion of urokinase as well as TPA from the vessel wall. So that's, I think, the beginning of why there are many reasons probably, but the beginning of why we see some people autolyse and solve their own clot versus others who stay with clot for a long time.
Thank you very much,
You're
Patty.
welcome.
Thank you.
Thank you.
Appreciate it.